واضح معاكم الصورة؟
Perfect.
Excellent. You have a bit of background أنا ما عندي background. I'm worried about surprise إن واحد من أولادي يطلع ورا كذا.
You have a curtain covering you. It's good.
أنا عندي الكاميرا للأسف اللابتوب is down وممكن كده تكون upward الإيميجينج بس أهم شيء إنها تسنتر نوعا ما. متى حنبدأ إن شاء الله؟ وقت معها؟ You want me to start now?
بس بتأكد منك
متوقع
تشوف
دكتور رولا؟
السلايد is moving صح؟ بس أنا أتأكد أنا.
Yes.
Okay, perfect. Okay.
No, slide is moving. I'm not sure the attendees are starting with us now or not yet.
تمام.
دكتورة مها بس تأكدي لنا. أخت مها الله يسعدك.
تفضل دكتور. المعدل بس قول لي إيش
Can we
محتاج؟
start now?
يس.
Can we start now خلاص ولا؟
أيوة دكتور.
خلاص ده أنت يلا. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. تحية طيبة للجميع. Good evening everybody. On behalf of the RSSA, I would like to welcome you to this webinar. It will be about traumatic shoulder injury. My name is Dr. Edith Beatty. I'm a musculoskeletal radiologist from King Faisal Specialist Hospital. So it is with great pleasure to welcome our speaker tonight, Dr. Rola Husain. Dr. Rola Husain, she is a diagnostic and interventional musculoskeletal radiology from Kingdom of Bahrain. She working in Suleimaniya Medical Complex, which is a government hospital in Bahrain. She is a holder of both Arab and European Board of Radiology. She have also musculoskeletal fellowship, one of them done at Mount Sinai Hospital, USA, and the other one at Vancouver General Hospital. She is a lecturer at the Arabian Gulf Medical University, Bahrain. She also secretary of Arabian Gulf Society of the skeletal radiology, and she will be the representative for this society at the Asian Society of Musculoskeletal. Please welcome with me Dr. Rola Husain, and the mic is yours, Dr. Rola.
Hey, thank you very much, Dr. Walid, for this kind introduction. Before I start, I would like to extend my thanks to the RSSA and in particular Dr. Nuha for arranging this. So thank you very much for having me tonight. Tonight we'll be talking about the imaging of traumatic shoulder injuries. They're basically quite common. We basically encounter them on, daily on-call basis. They in general depend on the patient's age and the mechanism of injury. Imaging play a very important role, especially in determining the mechanism of injury, deciding on the next best step in terms of for either acquiring further images or even the treatment itself, or even plan the post-operative follow-up. And also in some instances in trying to fish or look for some associated complications. All right. So basically tonight we'll be covering the following 5 segments. We have the proximal humeral fractures, glenohumeral dislocation, acromioclavicular joint injury, clavicular fractures, and scapular fractures. All right. As you know that the shoulder girdle is made of 3 bones. We have the clavicle, we have the proximal humerus, and we have the scapula. Plus, we have some articulations. We have the glenohumeral, acromioclavicular, sternoclavicular, and the thoracic scapular articulation. All right, let's start with the first, which is the proximal humeral fractures. Okay, this is quite common. Basically makes up to 60% of all upper extremity, or let's say extremity fractures. Now, this can come in one type of energy. So it could either be low energy, a type of low energy, and usually this involves elderly osteoporotic female, and the common mechanism of injury is FOOSH, which is fall on outstretched hand, or which is basically indirect, or it could be direct. This comes with high energy in the setting of trauma, in the setting of motor vehicle accidents, and most of the cases it's associated with glenohumeral joint dislocation and mostly seen in young individuals. Or it could be part of excessive shoulder muscular contractions in the setting of seizures or electrical shocks. Okay, so let's touch base on some basic anatomy. Now, this is the humerus, this is the glenoid, and this is the famous articulation. This is the greater tuberosity, this is the lesser tuberosity. We have the surgical shaft. The surgical shaft is the one that separates both tuberosities from the humeral shaft. Okay, so sorry, it's the surgical neck separates the greater and the lesser tuberosity from the humeral shaft. This is the anatomical head, which articulates with the glenoid fossa. This is the glenoid neck. This is the coracoid. Whenever you see the coracoid, lateral to it will be the anatomical neck of the glenoid, and this will be the lateral, or let's say the surgical neck of the scapula or the glenoid. All right. Then this is basically the frontal view. This is the Grasha view. What's the Grasha view? This is frontal view, but with internal rotation. So with internal rotation, the lesser tuberosity will be seen in profile. So again, greater tuberosity, lesser tuberosity, separated by the shaft with the surgical neck. This is the humeral head, and this is the anatomical neck. The anatomical neck is the site of insertion of the capsule. Beyond this point, anything will be extra-articular. So the neck will separate the head from the tuberosities. And again, you have the coracoid, the anatomical, and the surgical necks of the glenoid. And this is the axillary view, in which anteriorly you have the coracoid, posteriorly, again, not shown here, you have the axilla, the acromion. And this is the humeral head articulating with the glenoid fossa. Great. So with the proximal humeral fractures, what's the most common mechanism of injury? It's basically lateral momentum. What happens? The body goes into external rotation, the arm goes into internal rotation, and this will basically result in transmission of forces and high propensity for mid-shaft fractures. Either they're going to be spiral or oblique. All right, the other mechanism will be fall on an extended and abducted arm, which will result in hyperabduction. So basically what happens, where would the force go? There will be impaction of the greater tuberosity with the acromion over here, and this will result in higher propensity for greater tuberosity fracture and surgical neck fractures of the proximal humerus. Okay. Again, in a nutshell, this is the greater tuberosity, this is lesser tuberosity, separated from the head by anatomical neck, and these tuberosity separated from the shaft by the surgical neck. Great. So for proximal humeral fractures, basically we have 4 parts, and we usually follow the near classification. This depends on the number of displaced and or angulated fragments. Now, basically, I'm having 4 players in this setting of injury. We have number 1, the greater tuberosity. Number 2, lesser tuberosity. Number 3, the humeral head and the humeral shaft. So when I come to describe an injury in this area, I'm talking about an injury in relation to one of these 4 players. So what are my tools? What can I do? Like, what can I do as a radiological tools that help me diagnose this entity? Let's start with the bread and butter. Let's start with radiograph. First of all, we have basically the frontal shoulder radiographs. It's good. I basically see all the articulations and the bones that I need to see. Also, I can use the Grasha view. Again, a Grasha view is an frontal view, but with internal rotation. So basically what you see, a bit of widening of the glenohumeral joint. I'm basically opening the joint. Also, you can use the Y or scapular view. Anteriorly, you have the coracoid. Posteriorly, you have the acromion. And this is basically the humeral head articulating with the glenoid in the center. Also, you can use the axillary view, which we will see in the upcoming slides. All right, remember, the rule of 2 in the setting of trauma, never, ever, ever make your diagnosis based on one radiograph. The rule of 2 says 2 or more views are always necessary to evaluate any joint, any trauma, any fracture. Why? Because you can always be fooled, right? All right. So done with the radiograph, let's talk about the CT. How can the CT be useful in the setting of proximal humeral fractures? It's good to determine the morphology of the injury, degree of displacement, trying to fish for any associated fractures, for example, glenoid fracture, predict the if there's any chance of having osteonecrosis, and of course, plan for any preoperative planning, basically. MRI is good to look at occult fractures, and especially in the setting of high energy impact fracture. We're talking about 3 and 4 part fractures, the association of rotator cuff injury. Of course, whenever you're worrying of a vascular compromise, especially in the setting of a markedly displaced fracture, your friend would be the Doppler ultrasound or the angiogram. All right, now remember, we're doing near classification. So they range from 1, 2, 3 to 4 parts. How can I start by naming one part a real part? No part will be considered an actual part, except if it was displaced by more than 1 centimeter, or it was angulated by more than 45 degrees. Right. And remember, the actual number of fracture fragments does not necessarily reflect the actual number of the fragments. So again, as we stated earlier, these are our 4 players. In part 1, nothing is displaced, or if they would be displaced, they are minimally displaced. They don't cross the bar of 1 centimeter displacement or 45 degree of angulation. Part 2, one of these 4 players will be displaced more than 1 centimeter or more than 45 degree of angulation. In part 3, 2 of these players will be displaced more than 1 centimeter or more than 45 degrees of angulation. And in part 4, all of them will be guilty. Sure. Let's start with the first. So as we said, none of the parts is displaced more than 1 centimeter or angulated more than 45 degrees. They are either non-displaced or minimally displaced. Luckily for us, these make the vast majority of the proximal humeral fractures with 70 to 80 degrees, and they're almost always treated conservatively. This is an example of a minimally displaced surgical neck fracture. And this is an example of a minimally displaced anatomical neck fracture, both of which are what? Are 1 part, because there is minimal displacement. There is displacement that's less than 1 centimeter and angulation less than 45 degrees. This is an example of a 75-year-old female who fell while gardening 6 days earlier, and she's unable to move her arm. Now, what can you see? You will tell me that there is a fracture, displaced fracture involving the greater tuberosity, and there is an impacted fracture seen on the frontal and lateral view involving the surgical neck. However, this still remains to be a part 1. Why? Because I know there is a fracture. I know it is displaced, but it's not displaced more than 1 centimeter. It is not angulated more than 45 degrees. And therefore, this is minimally displaced, and therefore, this is a type 1 or 1 fragment fracture, as you can see here. All right, the 2-part fracture, at least one of the four players will be displaced more than 1 centimeter or angulated more than 45 degrees. Most of the cases, the surgical neck is involved, followed by greater tuberosity. Now, the greater tuberosity fractures are quite vicious, and if they go down, most of the time, they don't go down alone. They try to take something else with them. So these are seen in the setting of anterior shoulder dislocation. Anatomical neck fractures are also seen as a two-part in the setting of two-part fracture, and the lesser tuberosity isn't that common. And the two-part fracture basically makes 20% of the proximal humeral fractures. So again, as you can see in this example, we have a fracture. It's a complete fracture involving the surgical neck to the extent that is displacing the humeral head. And this is an example of a two-part fracture because it's only involving the surgical neck. That's the only part that's basically displaced. And this patient was treated later with plates and screws. All right. As we said earlier, the greater tuberosity fractures are aggressive and vicious. And if they go down, they try to take something else with them. So most of the time, they're seen in the setting of anterior glenohumeral dislocation and rotator cuff injury as well. Okay, the three-part fracture, basically the fracture line involves 3 or 4 parts, and at least 2 of our 4 players are displaced, more than 1 centi or more than 45 degrees of angulation. There are basically 2 patterns that are encountered in most of the cases. First is the greater tuberosity and the shaft, and the second is the lesser tuberosity and the shaft. And 3-part fracture usually make up to 5% of the proximal humeral fractures. Now, this is an example of a 3-part fracture. And as you can see here, we have a displaced fracture of the greater tuberosity and of the surgical neck. The 4-part fracture, this basically involves all of the 4 parts. 3 parts are displaced. And luckily, again, for us, these are quite uncommon. They usually have poor non-operative results. Why do they have a bad prognosis or even that there's a high need for surgery? Because the articular surface is no longer attached to any part of the humerus. And we will talk about this in a bit more detail in the upcoming slides. Because of this, because the articular surface is gone or is affected, they will have a high incidence of osteonecrosis, and therefore they will require an operative management. All right. So as we said, these type of fractures are mostly treated with open fixation if surgery was appropriate for the patient. As you can see here, the lateral tuberosity is involved, greater tuberosity is involved, and the humeral head is dislocated. Why is the humeral head is dislocated? Because there's a displaced fracture of the lesser tuberosity and the greater tuberosity. Also, there is another fracture involving the surgical neck, and this basically makes it a 4-part fracture. All right, so in this example, this is a 65-year-old female with proximal humeral fracture. As you can see, there's a fracture involving the greater tuberosity over here and a fracture impaction within the surgical neck. We did a CT scan for the patient. Again, we have a surgical neck, we have a greater tuberosity. All right, wasn't really sure to call it a 4-part fracture. It was actually a 2-part fracture, but the lesser tuberosity is involved. So basically, we have a displaced fracture of the lesser tuberosity, we have a displaced fracture of the greater tuberosity. Because both of these are found, the humeral head was displaced. Most of the time, the humeral head is displaced because you have a displaced fracture of the greater and the lesser tuberosity. So this is 1, this is 2, and your 3rd player was the surgical neck. And this makes a 4-part fracture. Therefore, never, like if you have a high level of suspicion, don't jump into conclusion. Don't make your diagnosis only based on the radiograph. Utilize your tools. You have access to CT scan, do a CT scan. Because if we didn't do a CT scan, we wouldn't really be sure and know that the lesser tuberosity was actually involved. All right. If I would talk about 4-part fracture, there is a special type. There is a type that basically called a valgus impacted 4-part fracture. I know by default, if I said 4-part fracture, I would panic. I would think there's something bad. The patient will have a bad prognosis. But this variant actually isn't bad as it sounds. Usually these cases, what happens is that we have a valgus impaction between the head and the shaft. And most importantly, what's the buzzword? Your articular surface is saved. That's where the money is. If your articular surface is saved, there is less chance of having an osteonecrosis, and therefore there is a better prognosis for the patient. Most of these cases are basically treated with closed reduction or limited open reduction and minimal internal fixation. And around 3/4 of them will have a satisfactory result. Now, this is an example of a bad 4-part fracture, and this is an example of a valgus 4-part fracture. What's the difference between both of them? This is the bad, this is the good. Why is this good? This is the humeral head. The humeral head is intact. I know this is a 4-part, but this is where the valgus is, and your humeral head is intact. So this should be good. Whereas this one, the humeral head is gone. Why? The lesser tuberosity again is gone, greater tuberosity is gone, and therefore your humeral head is dislocated, and this is a bad 4-part fracture. This is a good one. All right, so this is valgus. Now, again, just like we have valgus, we have varus injury. And varus injury, if it was seen in any of the parts, whether it was 2 or 3 or 4, it will always be bad. So valgus is good, varus is bad. Why is varus is bad? Because again, your articular surface will be involved. This is where the blood supply is. And if this was disrupted, this will end up with bad prognosis. Okay? So valgus is good, varus is bad. All right. Near classification has its limitation. First of all, it's arbitrary definition of displacement of a given part. For example, if I told you I have 1 centimeter displacement or a avulsion fracture of a greater tuberosity, that will be a 2-part fracture. But if I told you I had a greater tuberosity fracture and I had a surgical neck fracture, each of which measures 9 millimeter, if I add them together, that will be a non-part fracture because it doesn't make to the criteria. The criteria says 1 centimeter. Again, that doesn't really make sense in the practical life. Also, the near classification does not talk about the articular split and osteochondral impaction fracture. Why are these important? They're important because they will determine the likelihood or the risk of osteonecrosis. Also, displacement is quite difficult to measure on radiographs. If you have access to more studies, great, but if you didn't, this criteria will really limit you. Okay, therefore, if I'm talking about osteonecrosis, I will have to discuss the intracapsular fractures of the proximal humerus. Now, we left the near classification. We're talking about this in general, and in particular, the intracapsular fractures. Okay. Now, why do I worry? Why is this important? It's important because the blood supply of the humeral head comes in a retrograde fashion from distally to proximally, right? Now, where could it be disrupted? Or which are the alarming fractures? Fractures that involve the anatomical neck, 4-part fractures that involve greater and lesser tuberosity. Remember, we said if greater and lesser tuberosity was displaced more than 1 centimeter, then your anatomical head will be displaced. And of course, comminuted articular split fractures. All right. As I said, the blood supplies comes this way. So this is the axillary artery. Axillary artery gives you anterior circumflex, posterior circumflex. Now, the anterior circumflex wraps around the surgical neck. And this is basically seen 8 millimeter below the articular surface of the glenohumeral joint. So, in other words, any fracture involving this area, I would worry because this will disrupt the blood supply. Now, the anterior circumflex will give you the arcuate artery to supply the humeral head. You can receive further supply from the rotator cuff through the greater tuberosity as well. All right, so again, as I said, remember I said the money is within the medial periosteum, and this is where I would worry. This is if I had a fracture line extending here, this is where I would worry about a blood supply compromise. All right, so what are the predictors based on what we said? What are the predictors of a humeral head ischemia? If I had less than 8 millimeter of a bone length attached to the articular fragment. So if a fracture line was found within this 8 millimeter interval, this is number one. Number two, disrupted medial hinge. As we can see, this is the medial hinge. All right, and this is when it's displaced, and this is when it's dangerous. Number three, increase in fracture complexity, displacement more than 1 centimeter, or angulation more than 45 degrees. All right. Let's talk a bit about the articular split fractures of the humeral head. Now, these can come in two flavors. They could be simple, so it's just a simple line involving the articular surface, or it's comminuted, where more than two anatomical head fragments are found. Now, in general, fractures extending through the articular cartilage are difficult to reduce, and they have a bad prognosis that worsens with the patient's age. All right. This is an example of a simple articular fracture. As you can see, this is a simple fracture line. This is an example of, okay, I know we have a complex fracture. This fracture is basically involving the surgical neck, but we also see a fracture line through the humeral head. Now, is it simple? Is it complex? I can't really determine on the radiograph. I need to do further imaging. So we do a CT scan. As you can see, it's basically, it has two or more, right? Fracture fragments of the humeral head. So lesser tuberosity is involved, greater tuberosity involved. This is basically a comminuted or a complex fracture with intra-articular extension. Okay, so again, to repeat. So any fracture involving the anatomical neck will end up with isolation of the anatomical neck from all capsular attachment. That's bad. Any fracture separating the greater and lesser tuberosity will basically isolate the anatomical head from the shaft. And fractures involving the medial periosteum of the humerus, again, is bad. So a combination of these will increase your risk of having osteonecrosis up to, or ischemia in 97% of, or there's a 97% risk. All right, so this is basically an example of a fracture. This fracture is involving the greater tuberosity, the lesser tuberosity, again, and the surgical neck. But what did we say? Greater tuberosity fracture, lesser tuberosity fracture. What's the end result? The humeral head will be displaced. And as you can see in this image, it's basically displaced laterally. And then high risk of ischemia. All right. Proximal humeral fractures could be associated with glenohumeral dislocation. And basically, they can have intra-articular extension, and patients might present with instability, pain, high likelihood of heterotopic ossifications, and neurovascular compromise. And basically, you will need to correct them surgically. All right, this is an example of another patient. As we said, greater tuberosity is involved, lesser tuberosity is involved, surgical neck is involved. But again, greater and lesser tuberosity involved, and result is dislocation of the humeral head into the axilla, and that's basically happened in association with glenohumeral dislocation. And as we said, since all of these are found, this will increase the likelihood of ischemia. So even though this patient was treated on time, even though this patient was treated surgically, 1 year later, when he came for follow-up, there was basically osteonecrosis of the humeral head. All right. These types of fractures, as you can see, again, this is displaced humeral head, can result with neurovascular compromise. And in this example, as you can see, there's a bit of stenosis involving the axillary artery. And luckily for this patient, this was successfully treated with a stent. All right. Because ischemia is important, and determining the likelihood of having ischemia, they came up with a specific criteria. that will determine your likelihood of having ischemia. This is not really important, but I'm just going to quickly walk you through it. So basically, this classification is divided into 3 categories. The higher, so in type A, less likelihood of developing ischemia. In type B, you have 50-50 chance, and in type C, it's definite or high likelihood of developing an ischemia. In type 1, it's basically extra-articular. So again, see, the articular surface is clean. Articular surface is clean, less likelihood of having ischemia. So either it can involve the tuberosity, it could be impacted metaphyseal or non-impacted metaphyseal. In type B, again, it's extra-articular, however, it's bifocal. So it can have metaphyseal impaction, without metaphyseal impaction, or with glenohumeral dislocation. And again, in this type, you will start worrying about having a risk of osteonecrosis. In type C, there is an articular involvement. Again, see, this is involving the critical zone, the 8 millimeter that we spoke about earlier. So in type 1, there is slight displacement. Type 2, it's impacted with marked displacement. In type 3, it's basically displaced and dislocated into the axilla. Okay, so to repeat, factors predictive of ischemia, fractures involving the anatomical neck, medial metaphyseal segment that's less than 8 millimeter, and if there was displacement more than 2 millimeter of that part, as a rule of the thumb, not a rule of the thumb, I'm just saying if you could have the chance to include in your reports the thickness around the fracture, so the cortical thickness around the fracture. Why should we care about that? Because the orthopedics usually require 4 millimeter of a bone around the area in order to have a successful internal screw placement. Okay. In general, proximal humeral fractures, most of the time, as we said, they're type 1 or 1 fragment, and they will successfully be treated with conservative measures. Surgery usually depends on the patient's age, bone quality, rotator cuff involvement, fracture severity, and how active the patient is. All right, what are the complications that might be associated with proximal humeral fractures? We have nerve injuries. In some instances, there could be permanent motor dysfunction. Around 60% of cases, there could be axillary nerve involvement, and in 50% of cases, there could be suprascapular nerve involvement. Vascular compromise, as we saw in that example, the axillary artery, and they could be associated with brachial plexus injuries as well. Loss of range of motion, and that's in cases of adhesive capsulitis, and osteonecrosis could be seen in around 33% of cases. Now, what are the surgical options for proximal humeral fractures? We have plate and screw fixation, intramedullary nailing, tension band construction, and hemoarthroplasty or reverse total shoulder arthroplasty, and that's specially reserved for elderly patients. This is an example of plates and screw fixation. This is an example of intramedullary nailing. And this is an example of a tension band construction, and this is an example of a hemiarthroplasty. All right. Even if we treated these patients, there are some expected post-operative complication. For example, you might have a proud screw. The screw might penetrate through the humeral head for cases of open reduction internal fixation. There could be humeral head avascular necrosis, around 9%. And there could be chronic instability after arthroplasty, and there still could be a loss of range of motion, and especially with cases of arthroplasty. All right, so in a nutshell, when we report, what do we need to say? What are the involved fracture lines? What are the involved 4 players that we spoke about earlier? Is there any displacement more than 1 centimeter? Is there any angulation more than 45 degrees? Is there any intra-articular extension? And again, when we talk about articular split, it could be simple or comminuted. Is there any anatomical neck fractures, or is there a greater and lesser tuberosity that will make an anatomical head fracture? And if the anatomical neck was disrupted, do we have an 8 millimeter preserved around the surgical neck? or do we have more than 2 millimeter displacement? Again, to determine the risk of osteonecrosis. And of course, don't forget to mention if there was any associated glenohumeral dislocation, again, the location, the direction of the dislocation, and if there are any interarticular loose bodies as well. All right, we're done with the proximal humerus. Let's shift the gear and talk about the glenohumeral dislocation. All right. The glenoid covers 1/3 of the humeral head articular surface. If the joint capsule was lax, it will, and usually it's lax, it will make it susceptible for instability. It will make it prone for dislocation. Around 50% of these dislocations occur in young men. And 90% of these dislocations are anterior, and 2 to 4% are posterior, and least around, which are around 1%, are laxatio erecta. And this is inferior dislocation. All right. I like to think of the glenohumeral joint as a scoop of an ice cream on top of a biscuit. Any disruption of this configuration will result of instability and, of course, dislocation and hence instability. All right. Let's talk first about anterior shoulder dislocation. As we said, mostly affect young males or even elderly females and males. The mechanism of injury is forced abduction with external rotation and extension. What happens is the humeral head will dislocate anterior and to the glenoid, and it will be inferior to the coracoid. So again, this is how it appears on the frontal view. It will go inferior to the coracoid, and on the Y view, you will see that is it's going all the way anteriorly. So again, your compass is the coracoid. Coracoid means your anterior, acromion means your posterior. The humeral head has to be found over here. If it moved from dislocation, if it went anteriorly, below the acromion, below the coracoid, this is anterior dislocation. If it moved posteriorly, then that's, below the acromion, that's a posterior dislocation. These types of injury could be associated with other forms of injury. We could have an impaction of the posterior lateral aspect of the humeral head. That's what we call a hill sag, or we could have an associated bony injury involving the inferior aspect of the glenoid, which we call a bony Bankart lesion. All right, so what happens in anterior dislocation? The humeral head moves all the way anterior to the glenoid. And as it rotates, it's going to, the posterior lateral aspect of the humeral head will impact upon the anterior inferior aspect of the glenoid. And this is what we call a hill sag lesion, as you can see in this example. All right. Another useful view in order to diagnose this entity is axillary view. It's nice because it shows you or confirms whether there is or there isn't a dislocation. Again, this is the coracoid. So if I see the coracoid, I know I'm anterior, and this is the acromion. If it went that direction, that's anterior dislocation. If it moved backward, that's posterior. Now, before I jump into a conclusion and I get excited and I call it dislocation or I draw a diagnosis, I need to ensure, first of all, that this radiograph was taken in the correct technique. How can I ensure this is a true axillary view? Is when you see the eye sign. If you saw the eye sign, yes, that's a true axillary view. If not, then repeat or ask for another view. All right. Another additional useful view is the Bernard-Jault or West Point profile view. This is basically useful for cases of recurrent anterior instability, posterior instability, and post-operative assessment following the coracoid transverse procedure. This is done basically for Bankart lesions, which is called the Latarjet operation. Basically, the patient is standing and the beam is directed 60 degrees to the torso. Why is it good? Because it gives you a beautiful depiction of the glenoid. So here you go. This is a case post-coracoid transfer. As you can see, the screw transfixing it. And this is a case comparing a normal glenoid, normal, sharp, and smooth glenoid border with a case of a glenoid loss, which is basically a Bankart lesion. So again, what am I trying to look for? In this view, I try to see a piece of a chopped bone. This is what I call a cliff sign or a blunted ankle sign. And this is what would tell me whether I'm having a Bankart lesion or not. Again, these could be seen if we have limited access to cross-sectional imaging or if I really needed to give a fast diagnosis. All right. Other radiographic views are useful. Now, frontal radiographs could be done and with certain movements. If I do internal rotation, I'm basically bringing the lesser tuberosity into profile. If I do external rotation, I'm bringing the greater tuberosity into profile. So this is an example of frontal internal rotation view of the shoulder that shows you Hill-Sachs lesion. This is a striker view and basically is done with the patient's arm above their head, and it beautifully shows you the Hill-Sachs defect. And this is another example of a West Point or Bernard-Jault view that shows you the bony pancreatic lesion. All right, so CT scan is useful to further decide on the morphology, determine the mechanism of injury, to see if there is any interarticular loose bodies, any associated fractures, and the degree of glenoid bone loss. All right. It's good even to know if there are any reasons or causes for the dislocation. For example, in this image, you can see there's a bit of glenoid hyperplasia. This is anterior, this is posterior, and glenoid hyperplasia is a reason or a cause for posterior shoulder dislocation. This is an example of a Hill-Sachs lesion involving the posterior lateral aspect of the humeral head. This is an example of a bony pancreatic lesion involving the anterior inferior aspect of the glenoid. This is an example of an engaging Hill-Sachs lesion. Again, Hill-Sachs impacting on the anterior inferior aspect of the glenoid. This is how it looks like on a 3D CT representation. And this is an example of a posterior dislocation. On CT scan, because we have 3D setting, we basically can determine, utilizing this method, how much of the bone has been lost. Why is it important? Depending on the amount of bone that's lost, it will tell me whether a surgical intervention is necessary or not. So basically, it easily enables you to measure the bony loss. All right, and this is another example of a bony pancreatic lesion involving the anterior inferior aspect of the glenoid. This is an example of a bony pancreas with a Hill-Sachs lesion. Sometimes the CT scan is useful to know if I have a reason. For example, if you have a patient that they try to do a reduction, but it was unsuccessful, we need to know why, right? And CT scan can help us answer the question, because in some settings, the reason could be the presence of intra-articular loose bodies. So it's important, if you were reporting, to mention the presence of intra-articular loose bodies as well. All right, MRI is good to look at internal structures. It's good to look at glenohumeral ligaments. It's good to look at the labrum's type of injury, the size, and the injury of the periosteum as well. So as you can see, this is an example of Hill-Sachs lesion, and this is an example of a labral injury. So this is involving the anterior inferior labrum. Right now, the labrum is made of fibrous tissue. And if it's made of fibrous tissue, it should be of a low signal intensity on every single sequence on MRI. If it started to become bright, then you know there is an abnormality. Now, the labrum over here does not look as nice and pretty as the one within the posterior aspect. So you know there is an abnormality in the labrum. Also, if you can trace the bone, you will see that there is a small piece of bone that's actually chapped. So this patient has a soft tissue and a bony pancreatic lesion in the same setting. All right. If I talk about labral injuries in the setting of Hill-Sachs injuries, I have to talk about engaging and non-engaging lesions. Why? Because they will decide on any further management. Now, how can I decide? First of all, I have to group my players. So what are my two important elements in order for me to decide whether it's engaging or not? Number one, we have the Hill-Sachs interval. What's the Hill-Sachs interval? Basically, you're measuring the width of the Hill-Sachs defect, and you also measure the distance of this defect from the site of insertion of the rotator cuff into the greater tuberosity. Then you have to measure your second element or player is the glenoid tract. How do you measure it? Basically, you will have to draw a circle around the glenoid, and that's basically done on a sagittal view. And then you measure the entire width of that glenoid, and then you basically measure the amount or the width of the bony loss. So a glenoid tract is 0.83 multiplied by the whole width minus the bony loss. Great. Once I have my two elements, and my two pliers, I can determine whether it's engaging or not. So if it's engaging, the Hill-Sachs interval will measure more than the glenoid track. Why is it important to know if it's engaging or not? Because the engaging lesions usually will be unstable. There's a big defect. This defect has all the luxury to keep engaging and to engage and get stuck on the glenoid. And that's a big reason of instability, and definitely you will have to intervene. The non-engaging one, basically the glenoid bony loss will be more, or will measure more than the Hill-Sachs interval. And this is when we might have to do the letter J procedure, which we spoke about earlier. I'll talk about it a bit in the coming slides. All right. Shoulder instability could be a consequence or a complication because of anterior shoulder dislocation. Also, not only in the setting of Hill-Sachs or in the setting of Bankart lesion, but also can happen when the labrum is injured in other settings. For example, we have Perthes lesion, and this is basically happens when the labrum is torn, but the periosteum is intact. Again, as we said, the Bankart lesion, the labrum and the periosteum, both of which are cut. And here I'm talking about soft tissue Bankart, because the bony Bankart will be when a small chip of bone is basically avulsed as well. ALPSA is basically Perthes. So the periosteum is intact, the labrum is torn, but it goes, or it displaces more medially. And the GLAD lesion is basically when I have a labral tear and it extends into the cartilage. Bear in mind, these three will result in instability except for the GLAD lesions. All right. The slab tears can also result in instability. We basically have 10 types. They're beyond the scope of this presentation, but I just wanted to bring it to your attention. In general, the treatment of anterior and posterior instability is surgical repair with strengthening of the capsule. In cases of multi-directional instability, the patients may benefit from conservative management with rotator cuff strengthening. And always remember to evaluate in the setting of anterior shoulder dislocation the amount of bony loss of the glenoid. If it was more than 20%, then this might be a beginning of more deterioration and instability, and the surgical intervention is imminent, in which there is a coracoid transfer. So what happens here for cases of a bony loss, bony Bankart, bony loss of the glenoid, what do the surgeons do? They take a piece of the coracoid with its muscle attachment, and they transfer it to the glenoid, trying to fill in the gap, and that will result in stability. Another procedure is the remplissage procedure, and basically they will try to fill in the gap of the Hill-Sachs lesion by inserting the infraspinatus. So pretty much you're having like a puff pastry, and you're just filling it in this instance with an infraspinatus. All right, complication. Basically, there is high likelihood of recurrent instability, 14 to 100% of cases. So basically, it's a range. There could be, and that would happen because in many instances, there could be a damage of the inferior glenohumeral ligament. That is a key shoulder stabilizer, especially, and if it was torn, it will predispose the shoulder to undergo recurrent dislocations. The axillary artery could be at risk in up to 50% of cases, as well as the brachial plexus. All right. As for the posterior shoulder dislocation, the humeral head will be displaced posteriorly. This basically happens in the setting of a direct anterior trauma or seizure. What happens basically is the humeral head will be dislocated posteriorly in relation to the glenoid. Now, what is involved here? The anterior medial aspect of the humeral head and the posterior aspect of the glenoid. So we have reverse Bankart and we have reverse Hill-Sachs. These types of injury could be associated with cases of high contractures, like seizures or electrical shocks. Now, they're quite subtle. and they're quite tricky, and they could be easily missed. And because of that, I try to include a couple of tricks in trying to fish and find them. So first of all, we're trying to look for the light bulb sign. What happens basically here is that because the patient will be fixed in internal rotation, the humeral head will take the configuration of a light bulb. Also, in a normal frontal radiograph, you have to have the half-moon overlap sign, and that's when the humeral head overlaps with the glenoid. If you see this in an anterior radiograph, that's normal. Now, if I'm doing an anterior radiograph and I had loss of the half-moon overlap sign and I saw widening of the glenohumeral joint, then think of posterior shoulder dislocation. So a trick is you are trying to take this image in a frontal radiograph, and instead of it appearing as a frontal radiograph with the presence of a half-moon spine, half-moon sign, you will see separation of the glenohumeral joint. So basically, it's like a Grashi view, but we actually try to take a frontal view. So always check with your tech how, before diagnosing, how was this image taken? Was it frontal or was it actually Grashi? Because it actually can differ and help you make the diagnosis. Another tip is the TRO sign, and that's basically when there is the impaction of the anterior medial aspect of the humeral head into the glenoid, which appear on the radiograph as another sclerotic line parallel to the glenoid. Last but not least, we have the disruption of the Maloney line. So if you notice on the inferior aspect of the glenohumeral joint, it should form a smooth, continuous configuration. If this was disrupted, there would be disruption of these Maloney's line, and you should think of posterior shoulder dislocation. All right. Last but not least, why not use your tools? Remember, you never make your diagnosis based on one radiograph. Always try to take 2 or more views. So you can see in this example, this is a frontal radiograph. You see some widening in the joint. And when we do our Y or scapular view, again, this is where the humeral head should reside on top of the glenoid. This is the cricoid, this is the acromion. If you can see, the humeral head is going all the way posteriorly and even actually behind the acromion, rendering this posterior shoulder dislocation. CT scan can also show us to know how much of the bone is lost. You can utilize whatever method makes you comfortable. All right. There are some, let's say, anatomical variants that can result in increased likelihood of posterior shoulder dislocation. One of which is glenoid dysplasia. And this happens when there is a loss of abnormality within the ossification of the glenoid. And what we basically see on radiograph is a shallow glenoid. All right. We see that on the radiograph. We can further confirm it on the CT scan by trying to measure the angle of retroversion. How can we do that? So first of all, we try to draw a line that goes through the middle aspect of the scapula. You draw another line that's perpendicular to it. Now, the first line is called the scapular line. This is the line that's perpendicular to the scapular line. And then you have the glenoid line. The glenoid line is the line that connects the anterior and inferior margins of the glenoid, and you basically measure the angle. It shouldn't be more than, it should be in the range between 0 and 7, and it should not be beyond 7. If it was more than 7 degrees, then you basically have glenoid retroversion. All right. This is an example of a patient who has glenoid hypoplasia. How do you know that? Basically, this patient has like the posterior aspect of the glenoid appears to be hypoplastic, and there is a compensatory enlargement of the labrum at this area. And there is also a couple of cystic changes over here. So this will draw your attention to a presence of paralabral cysts that are seen in a setting of an occult labral tear, posterior labral tear. Again, this is an example of an impaction fracture involving the anterior medial aspect of the humerus. So this is a reverse Bankart, and this is a fracture involving the posterior glenoid with disruption of the labrum at this location as well. And this is another injury involving the posterior labrum with disruption of the labrum and the periosteum as well. All right. So treatment of posterior dislocation basically depends on the size, duration, and a couple of patients' factors. Now, in general, defects that are less than 25% of the articular surface, they're treated with closed reduction, especially if they're stable, and they are less than 3 weeks old. So they're basically still acute. Open reduction is reserved for the unstable or the ones that we are unable to reduce. Defects that are between 25 to 50% of the surface area of the humerus will require transfer of the lesser tuberosity into that defect. And shoulder arthroplasty is basically reserved for defects that are more than 50% of the surface area. All right. In general, posterior shoulder dislocation, it's associated with glenohumeral and capsular injuries, and that in its turn would result in chronic shoulder instability, especially in older population with posterior dislocation. There could be high likelihood of rotator cuff injury. So always try to evaluate the acromihumeral interval in the setting of dislocation. And of course, there could be, although it's uncommon, but neurovascular compromise is still a possibility. The last type of dislocation is luxatio erecta, and basically I know it has a characteristic look. It's characteristically looking with an abducted arm, and the humeral head is displaced inferior medially. Right, it's characteristic, but sometimes you might be puzzled. Is that really luxatio erecta, or is it a subglenoid anterior dislocation? There is one tiny trick that might help you to decide whether it's this or that. So basically, if you draw a line through the spine of the scapula, it has to go perpendicular with the humeral head. So if it was this case, if it was the case, then yes, you can confidently call it a luxatio erecta. So in a nutshell, in your report, try to say whether the joint is congruent or not. If it's not, try to tell us where is it dislocated, anteriorly, posteriorly, inferiorly, or interthoracic. Is there any associated fracture within the humeral head or within the glenoid? So we're talking about Hill-Sachs, Bankart, reverse Hill-Sachs, and reverse Bankart lesions. And if so, try to tell us how much of the surface area is involved, and try to tell us about if there are any associated glenoid fractures, and of course, if there are any intra-articular fractures or any associated injury to the rotator cuff interval or rotator cuff. All right, we're done with 2. We have 3 more to go. Let's talk about acromioclavicular joint injury. All right, now, the shoulder girder stability is basically an arc, and it's basically made with the help of all these structures and ligaments. The acromioclavicular joint is kept stable by the coracoclavicular and acromioclavicular ligaments. Now, we have horizontal alignment and vertical alignment. The horizontal alignment is kept in place by the superior and inferior acromioclavicular ligament, and the vertical alignment is kept by the coracoclavicular ligaments, which are the conoid and trapezoid, and reinforced by the trapezius and deltoid muscles. So, the most common mechanism of injury is lateral compression fracture. Patients fall on the side. The trauma is transferred through the clavicle, so that there is high propensity to having sternoclavicular, acromioclavicular, and clavicular fractures. The acromioclavicular injuries make 10% of all shoulder injuries. Most of the time, they affect young adult men, and the mechanism of injury is a direct blow to the acromion in the setting of an adducted shoulder, and that basically happens in the setting of sports injury or a fall from height. So, patient falls on a lateral, we have a lateral force, and again, this will increase the propensity to injure the acromioclavicular joint, acromioclavicular ligaments, and the coracoclavicular ligaments. All right. They usually follow the Rockwood classification system. This is made or done based on the degree of damage to acromioclavicular and coracoclavicular ligaments, as well as the direction and the magnitude of clavicular displacement. Now, in type 1, there is just a bit of sprain, but nothing actually is torn. In type 2, there is a tear within the acromioclavicular ligament and sprain of the coracoclavicular. So we have a bit of over displacement, or let's say superior displacement of the clavicle. In type 3, it is displaced superiorly, but not more than 2.5 centimeter from the acromion. In type 4, the clavicle is displaced posteriorly. In type 5, it is displaced, it's far away displaced anteriorly, and I'm talking about the clavicle. And this is more than 2.5 centimeter from the acromion. And in type 5, the clavicle will be displaced anteriorly and will be trapped beneath the coracoid. So, the acromioclavicular ligament will be torn starting from type 2 and beyond, and the coracoclavicular ligament will be torn starting from type 3 and beyond. All right. So this is the acromioclavicular joint. It shouldn't be more than 6 to 7 millimeter. The coracoclavicular interval should not be more than 11 to 14 millimeter. And always try, if you had the chance, to compare right or left, and especially in some suspicious cases. In order for us to evaluate this area, again, we utilize our radiographs. We have the frontal radiograph, we have the Y or scapular views, and we have the axillary views. And basically, we're evaluating this area. This is the acromion, and this is the coracoid, and this is the clavicle. It's just explaining the axillary view. All right. There could be some special views, one of which called Zenka view, and that's done with 10 to 15 degrees of cephalic tilt. And what we basically do when we're doing this is that we, or actually, let me say that it can be in one of two settings. It could be done regular, or it could be done with weight bearing, in which you give the patient something to carry, and that will increase or attenuate the acromioclavicular and coracoclavicular distance. And if there was any subtle abnormality, it will bring it to light. The CT is good to look for occult fractures and clavicle positioning. MRI is good to look at internal structures and especially ligaments, trying to see any ligamentous instruction. Just as you can see in this sagittal stare, there's disruption of the acromioclavicular ligament and the coracoclavicular ligament, hence the edema in this area. All right. Rockwood classification, let's repeat them together. So in type 1, there's just a bit of sprain. Again, this is a comparison between right and left. As I said, if you have the luxury of comparison, especially in cases with suspicion, please do, because some might just pass it. If the history did not say that the patient is actually complaining, I wouldn't actually call it. But if you will compare right and left, you will see that there's a bit of separation on the side in comparison to the left side. And any discrepancy between 2 to 4 millimeter should actually be considered significant. This is an example of a type 2. And again, there is a tear within the acromioclavicular. However, the coracoclavicular are intact. So there will be a bit of superior displacement of the clavicle in relation to the acromion. This is an example of type 2, in which there's disruption, a bit of superior displacement of the clavicle and disruption of the acromioclavicular ligaments and some widening within the acromioclavicular joint. Again, notice that your coracoclavicular is intact. In type 3, your coracoclavicular is not intact anymore. So acromioclavicular is torn, coracoclavicular is torn, and so there will be more of a displacement of the clavicle in relation to the acromion. However, it's not more than 2.5 centimeter. This is an example of a type 3 AC joint injury on the left side. Again, as you can see, this if you compare right and left, the abnormality is on the left side, widening of the acromioclavicular joint and widening of the coracoclavicular interval. Another example of type 3. And this is another example of type 3. Again, as you can see, this is the coracoclavicular interval. You see some edema, then you know that there's some disruption within the ligaments. So this is basically a case of type 3 acromioclavicular injury. This is a case of a 55-year-old man after a fall. Now, if you notice at first glance that there is widening of a acromioclavicular joint, but there isn't much of displacement of the clavicle in relationship to the acromion. So like, shall we call this type 2? However, since you see this abnormal, or let's say fluid or edema within the coracoclavicular interval, this will draw your attention that you might have a rupture within one of the coracoclavicular ligaments. So rupture of coracoclavicular ligament, rupture of acromioclavicular ligament makes it to grade 3. Therefore, the MRI could be useful in cases where you want to distinguish between grade 2 and grade 3, even though at the first glance, we could just simply call this a grade 2. All right, in grade 4, basically, there is posterior displacement of the clavicle, and it's best to be appreciated on axillary or wide views. In grade 5, there will be marked displacement of the clavicle in relation to the acromion, and that's basically more than 2.5 centimeters. And in grade 6, basically, there is anterior displacement of the clavicle in relationship to the acromion. However, it could in most instances be trapped under the coracoid, or actually can get trapped within the subacromion space. All right. In general, for uncomplicated type 1 and type 2, patient usually undergo conservative treatment. In type 3, it's usually controversial. However, in high-grade injuries between type 4, 5, and 6, you need an MRI in order to determine a surgical intervention in the form of internal fixation in most of the cases, because in these instances could be associated with dislocation and associated soft tissue injuries. Now for type 3, as I said, is controversial. The profession of the patient might play a pivotal role. So primary surgical benefit, usually younger patients with high functional demands, and surgery can also benefit patients with persistent pain or disability after a trial of conservative measures. Now, how do we treat them? We can treat them with a surgical wire. This is again an example of type 3 acromioclavicular joint disruption. Widening of acromioclavicular joint, widening of coracoclavicular joint. So this is type 3. And of course, there is a teeny tiny chip of bone, so there was a displaced fracture as well. And this case was treated with a surgical wire. This basically is a case of a complication because the surgical wire has to encircle the coracoid. You use the coracoid as a stabilizing factor. And in this case, there has been some displacement of the wire. This is another method of surgical treatment is hook plate, but this basically needs to be removed because it can end with some complications itself. In this example, this patient, after removal, as you can see, we have attenuated and accelerated osteoarthritis of the AC joint. This is another example of a patient who underwent hook plate, and it was done for a type 3 AC joint injury. However, the patient presented 6 months later with pain, and when they did further imaging, they saw that there has been some superior displacement. The hook plate should be going through the clavicle and the acromion, but it basically has displaced superiorly bypassing the acromion. So that's one of the complications. In general, complications could be post-traumatic arthritis, patient presents with pain, could have chronic shoulder joint instability, especially if there was neurovascular compromise with brachial plexus pathology. One of the complications as well is post-traumatic distal clavicular osteolysis. Usually patients present with pain with an arm abduction and flexion, even though it's self-limited, but it's quite painful. How do we diagnose it? On Zenker views, most of the time it's treated conservatively, and in some instances, they might need to do some distal clavicle resection. This is an example of a patient who had a coracoclavicular joint ligamentous reconstruction, as you can see here. However, as you can see, we have some reabsorption of the distal third aspect of the clavicle, which was consistent with post-traumatic distal clavicular osteolysis. Surgical pins can also be used in order to treat, for example, as you can see, the K wires, but we have to be cautious with them because they tend to migrate into the pleural space, spinal canal, and adjacent vascular structures. So frequently try to have some follow-ups and check the position and try, if possible, I mean, the surgeon would basically try to remove them after initial training, healing. All right, so in a nutshell, for acromioclavicular injury, first of all, we need to establish, is there widening of the acromioclavicular interval? If it's unclear, try to get a contralateral side, any discrepancy between 2 and 4 millimeter, or if you did a stress test, for example, the Zanka with weight bearing, then yes, it will further confirm your diagnosis. Is there any disruption of the coracoclavicular ligaments? Is the coracoclavicular interval more than 40 millimeter? Then that's abnormal. And if you had all this information, which type of AC separation is present? And are there any fractures of the clavicles or the coracoid which can impact the surgical repair? We try to answer these questions in our reports. All right, clavicular fractures. These are quite common because of their superficial location. The clavicle is basically the last bone to fuse. Therefore, it's quite common to be injured in kids, making up to 5% of all pediatric fractures. The clavicle fracture makes 2 to 4% of all fractures, 35 to 45% of all shoulder girder injuries, and 85% of sports or recreational injuries. Again, how does this happen? Lateral compression. So the forces travel through the clavicle. Again, it could be sternoclavicular, midclavicular, or the acromioclavicular junction. Why is the clavicle important? Because it's a site of insertion of some of the important muscles. For example, we have, and this is seen on a posterior view. Laterally, we have the deltoid and the trapezius. And medially, we have the pectoralis and the sternocleidomastoid, in addition to the coracoclavicular ligaments as well. How do we diagnose clavicular injuries? We have normal radiographs, frontal radiographs, or we can also do a Zanka view or special clavicular views with 20 degrees of angulation. MRI is good to assess the coracoclavicular ligaments, and CT is good to look for any proximal clavicular fractures or sternoclavicular dislocation or any underlying structures or injuries associated within the chest or within the neck. All right. For clavicular fractures, we usually follow the Ullmann classification. So the clavicle is grouped into 3 parts. The most common type is group 1, which is basically involving the middle aspect of the clavicle. Type 2 is involving the distal aspect. Type 3 is involving the proximal aspect. In general, group 1 fractures that are most common, making up to 80% of cases. The midshaft is the thinnest part. That's why it's more vulnerable to get fractures. And in most of the cases, conservative therapy suffices, the form of immobilization using a sling or a figure-of-8 brace. However, in 2/3 of these patients might have persistent pain and fracture instability, and they might benefit from a surgical intervention. Group 2 of these fractures are 10 to 15% of cases. They basically involve the lateral clavicle, and these are further subdivided by a special near modification of Ullmann classification, in which they take into account the integrity of the coracoclavicular and the acromioclavicular ligaments. And remember, when the coracoclavicular ligaments are involved, they might increase the need for surgery. In group 3 fractures, these are basically rare, making 5 or even less % of all these fractures. And the medial aspect of the clavicle is involved, especially in the setting of direct trauma near the sternoclavicular joint. This is an example of type 1. As you can see, this is type 1 involving the middle aspect of the clavicle or midshaft. And basically, this was associated with a pneumothorax. This is another example of type 1. Again, this is mildly displaced midshaft of the clavicle. This is displaced shaft of the clavicle fracture, and there is a bony fragment. For type 2, we said this basically involves the distal part. Now, I will quickly go with you over the near classification for the distal clavicular fractures, just for you to know. Type 1, basically, this will be extra-articular. So it does not involve it is distal, but it does not involve the acromioclavicular joint. In type 2, this will be a bit medial to the coracoclavicular ligaments. In type 2B, now 2A is not going to involve these ligaments. In 2B is going to be seen in the middle between the two coracoclavicular ligaments. In type 3, this will be intra-articular. In type 4, this is basically seen in the setting of skeletally immature patients. And in type 5, there will be a comminuted complex fracture. So 2A, what happens in 2A? In 2A, as we said, this is going to be seen a bit medial to the side of insertion of the coracoclavicular joint, coracoclavicular. So here you go. This is the coracoid articulating with the clavicle, and this is where the coracoclavicular ligament should insert. The fracture line is seen actually medial to it. 2B, basically, it's seen in the middle between the two elements of the coracoclavicular, ligaments. This is an example of type 4, and this basically, it has a special setting, which is basically in skeletally immature patients. In type 5, basically, this is a complex comminuted fracture. Surgical intervention basically is considered in cases where we have 2 centimeters of foreshortening, when we have an open or impending open fractures, neurovascular compromise, severe deformity, when there is a compromise of acromioclavicular and coracoclavicular ligaments. Now, we do require surgical intervention because in some instances, because we worry about non-union. When should we worry about non-union or ununion? In cases where there is significant displacement or angulation in the elderly population, in the distal fractures, cases with deformity, and when there is associated scapular fractures. So in our reports, we try to describe the number, the size, and the location of these fragments in order to determine the preoperative planning. And the higher degree of comminution, there is a higher energy injuries and increased likelihood of additional injuries, for example, rib fractures, scapular fractures, vertebral fractures, and as we saw in this example, a pneumothorax. Complications of these fractures in general are complex regional pain syndrome, thoracic outlet syndrome, non-union. So in a study, they saw that most group 1 fractures were treated conservatively, as we said. However, 15% of these had non-union versus 2% of the ones that were treated surgically. And in group 2 fractures, they had a higher rate of non-union, reaching about 44% versus group 1 fractures. Operative options, we have plate and screw fixation, and we have intramedullary pinning. Post-operative complications might include wire and screw migration, pain, of course, and hardware irritation. Therefore, 8% of these patients will undergo removal. We might even have 5% of infection, or even have a transient brachial plexus neuropathy. So in our reports, we try to, first of all, say, is there a clavicular fracture? Where exactly in the clavicle? Is it mid? Is it lateral or medial? Is there displacement of the fracture fragment? What is the number, the size, and the location of these fragments? Is there any foreshortening of the clavicle? And remember, any foreshortening of 2 centimeters or more, that will be an indication for surgery. Is there a fracture extension into the acromioclavicular joint, so intra-articular extension? Is there any involvement of the coracoclavicular ligaments? Why? Because their involvement might mean that the patient might have to undergo a surgical intervention. And is there any other associated injuries like ribs, scapular, or vertebral fracture, or even pneumothorax? Last segment of our talk tonight will be the scapular fractures. These are rare, making 3 to 5% of all shoulder girdle fractures. The scapula actually is the primary anchor for the upper extremity. Therefore, the scapular fractures if they were not diagnosed, might result in chronic pain and disability. And usually the scapula is hard to fracture because it's surrounded by a lot of muscles, and usually it requires a high energy trauma, especially in the setting of motor vehicle accidents. So as you can see, this is the scapula. We have the acromion, the glenoid, the coracoid, we have the neck, and then we have the body. So again, we have the coracoid, this is the acromion, this is the glenoid fossa. Lateral to the coracoid, we have the anatomical neck of the glenoid. Lateral to the coracoid, we have the surgical neck of the scapula or the glenoid. This is the superior margin, and this is the blade or the medial margin of the scapula. And of course, this is the body. Now, for what sorts of imaging can help us to diagnose this entity? Again, radiographs and CT. Radiographs, especially the axillary view and the Y view, which is quite useful for scapular, body, and neck fractures. And CT is useful to look for any additional chest wall injuries and plan for any preoperative planning, or to even have a 3D reconstruction. So on a frontal radiograph, you can easily depict the acromion, the coracoid, the spine, and the glenoid over here. We have the neck over here, and this is the body with the medial and the lateral and the superior borders. This is the wide view, again, the coracoid and the acromion with the blade over here with the body. And this is the axillary radiograph, as you can see. In this example, you see an impaction within the anterior medial aspect of the humerus, of the humeral head. Now, the Y view is quite useful, not only in the setting of anterior and posterior dislocation. As you can see, this is a case of anterior dislocation. It's seen below the coracoid. This is a case of posterior dislocation, and it's seen below the acromion. And all the time, on the Y view, the humeral head has to be superimposed or seen on the glenoid, so basically within the center. This is, again, an example of a West Point or Bernardo view, where you can see there is disruption of the anterior aspect of the glenoid. That's a case of bony Bankart with a small dislocated bony fragment. All right. Basically, the scapula is the site of insertion of 18 muscles with 6 different movements of the shoulder joint. The injury could be acquired through direct impact or a lateral compressive injury. Indirect forces usually are done through an axial transmission through humerus or muscular or ligament extraction. All right, first, let's talk about intra-articular glenoid fracture. They usually follow the Eidberg classification, and there are 6 fracture types. Type 1, it's a true glenoid fracture. Type 2 to type 6, it's a glenoid fracture with varying extension through the scapular body. Again, we don't have to use any classification. It's just useful for us when we report our cases. So usually these intra-articular glenoid fractures are associated with chest wall injury in 95% of cases, rib and clavicular fractures, and pneumothorax. So again, lateral compression, and what happens is that the humerus will impact upon the glenoid. Now, this is type 1A of the Eidberg classification of intra-articular glenoid fracture. So here we're talking about glenoid fractures. Type 1A, it's when it's involving the anterior rim. Type 1B is when it's involving the posterior rim. Type 2 is when it's going through the glenoid fossa and then tracks all the way inferiorly into the lateral margin. And this is an example of this type of fracture, example of type 2. As you can see, it's tracked through the glenoid fossa and tracking all the way inferiorly. Type 3 is basically when it's going through the glenoid fossa and then into the superior margin. And we have type 4 when it goes all the way into the medial margin. Type 5A, it basically has a T-shaped and goes in inferiorly and into the medial margin. VB, when it's separating the glenoid fossa, it has superior and inferior parts, and then it goes into the superior margin. And type C, it's a conjunction or a combination of type 5, 1 and B, 1 and 2, which is basically, it's a T shape going medially, going superiorly, and going inferiorly. And type 6, it's when it's a comminuted complex fracture. Usually type 1 fractures are treated surgically when marked instability is present, or if the fracture fragment is more than 25% of the anterior glenoid rim or more than 33% of the posterior glenoid rim, or if there is more than 1 centimeter displacement of the fracture fragment. Type 2 to type 5 usually are treated surgically if they are unstable, or if there is more than 5 millimeter of articular displacement or with the nerve injury. And type 6 usually are seen in the setting of severely comminuted injuries, as we said. And however, surgery is generally contraindicated because what's the benefit? It wouldn't much improve the function. We're done with the intra-articular glenoid neck. Let's talk about the extra-articular glenoid neck fractures. Usually what happens, it's a fall on outstretched arm, fouche. Humeral head impacts on the glenoid after a direct lateral impact. Type 1 usually are non-displaced, and they respond well to non-surgical treatment. Type 2, when there is more than 1 centimeter displacement or more than 40 degrees of displacement and or rotation, and this would usually require surgical repair. These fractures of the extra-articular glenoid neck are described relative to the coracoid process. Now, as a rule of thumb, if the fracture line was lateral to the coracoid, then it's involving the anatomical neck fracture. If the fracture line was medial to the coracoid, then it's involving the surgical neck fracture. And I'm talking in relation to the scapula. Now, the anatomical neck fractures are bad, and these are unstable and usually require surgical repair. And in these types of injuries, usually the patient can end up with a floating scapula. When do I call it a floating scapula? So, most of the setting, there is a fracture through the anatomical neck of the scapula, and there is an associated injury to 2 or more of these structures that make the stability of the shoulder girdle. So could be the clavicle, could be coracoclavicular, coracoacromial ligament, or it also could be the acromion itself. Let's see. So in this example, it's a 21-year-old male who was involved in a motor vehicle accident. As you can see, we have a fracture line. This is the coracoid. This is the coracoid, and we have a fracture that basically is involving the scapula, and the scapular fossa is basically displaced. Also, there is disruption of the acromiclavicular injury. So the neck of the scapula is involved, and another one of the key elements of stabilizing the shoulder girdle is involved, and that's when we call it a floating scapula. So acromiclavicular and surgical neck and the anatomical neck of the coracoid. And of course, the base of the acromion was involved in here as well. In this example, as you can see, we have a fracture that's basically involving the neck of the scapula, but also is associated with the clavicular fractures. So 2 of the key elements that keep the shoulder girdle is involved, and this will render it a floating scapula injury. All right. When do I call it a floating shoulder injury? It's an unstable form of injury and basically involves the shoulder girdle, in which 2 or more of these elements that are supposed to keep the piece or supposed to keep the shoulder girdle stable is disrupted. It could be the scapular neck, it could be the clavicle, it could be the acromion, it could be the coracoid, or it could be disruption of the acromiclavicular or the coracoclavicular ligament. Luckily, these are rare and they make less than 0.2% of the shoulder girdle fracture pattern. As you can see in this example, this patient has a fracture within the neck of the scapula, but also has a fracture within the clavicles. Also, there are some associated rift fractures. So also remember to evaluate this area as well. And don't be satisfied, don't have the satisfaction of surge or only focus on the elephant of the room, because other structures could be involved as well. This is another example of a patient who had type 3 acromioclavicular injury. Why did I say type 3? Because disruption of the acromioclavicular and widening of the coracoclavicular. That makes it type 3, according to the Rockwood classification. And there is also involvement of the scapula as well. Scapular body fractures, they make 50% of scapular fractures. Mechanism of injury is direct impact on the scapula or sudden muscular contraction with seizure and electrical shock. This is an example of it should be a 15 or a 5-year-old woman with a comminuted fracture involving the body of the scapula. As you can see, the wide view is quite useful to evaluate this area. Most of these scapular fractures undergo conservative treatment. Fractures of the scapular body rarely require surgical intervention, except in the cases of severe displacement. And for a glenohumeral joint fracture, the comminution, degree of displacement, and angulation will play an important role to decide whether the patient will undergo surgery or not. In general, minimally displaced fracture, less than 2 millimeter, of intra-articular fractures without comminution will go on a conservative treatment. If there is an articular displacement more than 5 millimeter, this will increase the post-traumatic degenerative process and the patient will require surgery. And overall, in cases of recurrent instability of the humeral head because of associated glenoid fracture, the patient will undergo surgery. Complications could be malunion or non-union, neurovascular injury, recurrent shoulder dislocation and instability, poor function, pain, weakness, and decreased range of motion. Last is acromial fractures. They usually follow the Kahn system, which basically divided into 3 types. Type 1 is non-displaced. Type 2 is displaced laterally with reservation of the subacromial space. Type 3 is when the fracture is displaced with narrowing of the subacromial space or involvement of the glenoid neck. Now, in type 1, A and B. Type 1 is when there is an avulsion fracture. Type 1B is when there is a true fracture, but it's not displaced. Neither 1A or 1B is displaced. Type 2, when there is displacement, but the acromioclavicular interval is preserved. Type 3, there is displacement, and it's either going or narrowing the acromioclavicular interval, or there could be another associated fracture within the neck of the scapula. All right. Type 1 and minimally displaced type 2 fractures are not encroaching on subacromial space, are usually treated conservatively with immobilization. Surgical fixation is reserved for markedly displaced type 2 and type 3 fractures. We worry about non-union, malunion, impingement, or even rotator cuff injury. This is an example of a 44-year-old man with a fracture within the acromion. However, he came for a follow-up CT 7 months later, and as you can see, there is non-union. This is another example of a patient, a 76-year-old man after a fall. As you can see, there's a fracture involving the acromion, but also there is some angulation, and this is resulting within reduction of the subacromial space. This is important because reduction in the space means there could be an associated rotator cuff injury and therefore might increase the likelihood of a patient undergoing a surgery. This is another example of a patient with acromion fracture and a reduction of the, as you can see, acromiohumeral interval, and this patient basically had a associated rotator cuff injury. Oh, actually, this is the last one, which is the coracoid fracture, not the acromion. The mechanism of injury is a direct blow to the shoulder from a lateral impact, or it could be due to a muscle avulsion or a direct humeral head impaction during anterior dislocation, or it could be a variant of acromioclavicular joint separation. There are 2 types in order to characterize the coracoid fractures. Type 1 is proximal, and type 2 is distal. When I say proximal distal, and that's in relation to the coracoclavicular ligaments. If we learned something today, we learned that this ligament is quite important in determining the stability of the shoulder girdle. All right. Why is the coracoid important? It's the site of insertion of so many muscle attachments and ligaments. For example, we have the coracoclavicular ligament, we have the trapezoid, and we have the conoid. We have the coracoacromial ligament, we have the transverse scapular ligament, and we also have muscle attachment. So medially, so we have the pectoralis major medially, and laterally we have the coracobrachialis and the short head of the biceps. There's another classification system for the coracoid, which is called the iris classification. Type 1 basically is avulsion of the tip. Type 2 is midpoint. Type 3 goes through the base. Type 4 goes through the base and into the body without interarticular extension. And in type 5, there's basically interarticular extension. This is an example of a 33-year-old woman with a subtle, as you can see here, subtle coracoid process fracture. This is an example of another 28-year-old woman after falling off her horse. And as you can see, the coracoid is fractured and there is some amount of displacement. Coracoid fracture can also be seen in the setting of anterior glenohumeral dislocation. As you can see, we have bony impaction within the posterior lateral aspect of the humeral head, denoting Hill-Sachs injury. There is no clear consensus on the treatment of coracoid process fractures. Usually, the ones that are non-displaced and minimally displaced, they will undergo conservative treatment. The markedly displaced one with acromioclavicular separation or displaced acromial fracture, clavicular fracture, or glenoid fracture will undergo surgery. So what do we need to say? Where is the scapular fracture? Is it within the neck, the body, the glenoid, the spine, acromion, or the coracoid? Is there displacement? And is it at the site of a muscle attachment? For the glenoid, is it intra or extra-articular? And if there is intra-articular, is there a displacement more than 5 millimeter? Remember, intra-articular displacement more than 5 millimeter will render it unstable. For scapular body fractures, does the fracture involve which aspect of the scapular border? Is there any malalignment of the glenoid with respect to the scapular body? And is there normal alignment of the glenohumeral joint? Because they could be dislocation could be associated with scapular fracture. And of course, don't forget to look at the image, trying to see any other associated injuries, whether involving the chest wall, the ribs, the clavicle, or even pneumothorax. All right, that's just a summary of what I said. So in conclusion, acute shoulder trauma is common. The type of injury varies with patient's age and severity of trauma. It's crucial for the radiologist to understand and report this imaging because we're helping the orthopedics to determine the mode of treatment, whether the patient will undergo conservative or surgical. Even we will help them to have preoperative planning. We'll also help them to look for complications pre-surgical intervention or also post-surgical intervention. And that's it. Thank you so much.
Thank you, Dr. Rola. This is a really great topic and presentation. Really amazing talk with the great images and illustration about the importance of these fractures and injury around the shoulder. I will reinforce what you said exactly. I think detection of the fracture is an important point, but the other important point is how you're describing these fractures. So as Dr. Rola mentioned, there is a lot of classifications, and these are important for the surgeon to determine conservative versus operative option for the patient. So thank you, Dr. Rola. I think we will move on now to the question and answers. So please, if you have any question, write them in the question and answer functionality in the Zoom. So we have already here a couple of questions. So I think, as you said, this is a great lecture. So some attendees are asking about recording of this lecture. So as I know, the RSSA are working with the website. So all these webinars will be, now it's already recorded and inshallah soon it will be published through their website, inshallah. They are working on the website. Also there is a question about if you explain more about the light bulb sign. So if you make it just a summary about the light bulb.
Sorry, Doctor, I can't hear you. Which sign? I'm sorry.
The light
the
bulb
light
sign
bulb sign.
for the
Yes.
posterior shoulder
Okay.
dislocation.
Definitely,
Definitely you can, if you have
Ahsan, I show it with image. What are we radiologists if we don't have images, right?
exactly.
Sorry.
While you're reaching that, maybe I answered it just only. It is just only a smooth clear picture of the humeral head during internal and external views.
See, we're here. Okay, perfect. So this, the light bulb sign basically, زين. الحين when we say that نحن we are doing a frontal radiograph of the humerus, shouldn't we have this? This is what we call اللي هو مثل lens shape, صح? This is the articulation بين الhumerus والglenoid. When we have posterior dislocation, the joint will look like it's separated, like this. So instead of having this overlap, there will be widening within the joint, and it will be fixed, it's fixed in internal rotation. And this will gives you the smooth configuration of the humeral head. So again, and a widening of the joint. So this is what you should look for. Again, this is a frontal radiograph, but looks like a Gracia view. Gracia view is a frontal radiograph with internal rotation. This is like a natural Gracia view, let's say that. So widening of the joint, loss of this moon overlap sign, or let's say the lens sign, and smooth or round configuration of the humeral head. This is basically the light bulb sign, because there is internal rotation of the humerus. So it gives you this appearance. I hope.
Excellent.
Yeah,
Thank you, Dr. Rola.
sure.
There is one question, another question. Somebody asked, is the clavicle the easiest bones to be fractured? So
Is it the
do you think?
easiest in the body?
Yes.
I think I'm gonna have to Google that,
Yeah,
but maybe
exactly.
because the
The
mid
scapula
aspect
in
is the
upper
thick.
arm.
Yeah, maybe because
Yeah.
the mid aspect of it is the thinnest. So yeah, maybe it is.
Yeah. But the number of the fractures, I think the scaphoids by far is the commonest fracture in the upper limb. But in pediatric age group, they are prone for clavicular fracture, yes. But if somebody asks about, is it necessary to, regard the limitation of the NIR classification, is it necessary to mention the type of fracture, especially the type need surgical intervention?
I'm sorry, Doctor, the question, is it, let me see.
So regarding the limitation of the NIR classification, is it necessary to mention the type of fracture,
No.
especially the type that need a surgical intervention?
No, it's not necessarily in describing any fracture in the body. Again, it depends at the end of the day with the orthopod that you're dealing with. Some of them will not feel comfortable with you giving them a classification. The point why we have classifications is just to help us or guide us in writing our report. Just to have like a checklist. Did I mention this? Did I mention this? Just try in your report to mention the most important points. You don't have to give a classification, because at the end of the day, your orthopod might not be familiar with it. So then it's going to be quite useless. What we're doing is we're trying to help them do their jobs. So by us giving a good description and covering the most important points, I think you're good. But you don't have to per se give a certain classification. And we also established that the NIR classification could result in more confusion, right? You cannot make your diagnosis on a radiograph because you have to determine how much of displacement, how much of angulation. We might be fooled with radiographs. And also it does not cover intra-articular extension. or the split fractures. It does not cover the part where there is dislocation of the glenohumeral joint. Therefore, it's better to give a description but rather than confining, like cornering yourself and giving a classification.
Okay, excellent. I totally agree with what you say. The description of the practice is more important. I think this is the last question that we have. Just a reminder for all the attendees. You'll be receiving a certificate for this webinar, and also you'll receive feedback and questionnaire, which will be helping the organization committee for these webinars. You want to
Dr.
share something?
Yes, I
Yes.
actually do need your help with this. We're going to have an ISS webinar. We're basically voicing out the women in the Middle East. This is part of the ISS. And it's going to be me and Dr. Lamia Jimjoum, like representing the region. And we would really appreciate your support if you can help spread the word and even join us in the webinar. It's going to be done in like around 2 weeks' time from today.
No, thank you. This is really great. And also, I will add also the announcement for the upcoming AMS. As you know, it will be holding in King Faisal Specialist Hospital in coming 14th of February. So I think this is a great opportunity for the attendees to attend this webinar also, and in physical the AMS meeting, the coming AMS meeting in King Faisal Specialist Hospital Riyadh. Really, thank you, Dr. Rola Husain, and I would like to thank all the attendees for their time, and I hope they enjoyed the webinar tonight. Thank you all. With this, we conclude our session, and thank you all.
Thank you.
يعطيكم
Thank you so
العافية
much.
جميعا. بالتوفيق.
Thank you, Dr. يعطيك
بالتوفيق.
العافية. Thank you, Dr.